Hello, this is Lee Myers, and I am going to present my capstone project, Pediatric Mild Traumatic Brain Injury in Sports, an Educational Intervention for Nurse Practitioners. The purpose of the research toolkit is to increase knowledge and awareness and promote quality health outcomes for individuals, families, communities, and healthcare systems. Welcome to the 2018 CDC and American Academy of Pediatric Guideline on the Diagnosis and Management of Mild Traumatic Brain Injury among Children. The CDC guidelines recommend using the term mild traumatic brain injury, MTBI, in place of concussion for consistency and no misinterpretation among stakeholders. Evidence suggests that there is variability in provider care, experience, and training, coupled with an explosion of previously published consensus statements and no formal United States guidelines, has led to uncertainty and inconsistency in the management of these injuries. The CDC offers 19 sets of clinical recommendations that cover diagnosis, prognosis, management, and treatment. The guideline is applicable to healthcare providers in all practice settings and highlights specific actions healthcare providers can take to help young athletes and their parents and caregivers cope. These include 5 key practice-changing recommendations. Number 1, do not routinely image pediatric patients to diagnose MTBI. Clinical evaluation of the child with possible MTBI includes balancing the likelihood of possible tragic complications of a more severe injury against the risks associated with head CT, such as radiation exposure and concomitant sedation imaging. If the provider suspects intracranial injury, then head CT is a preferred diagnostic tool in acute care settings, and the families and athlete should be counseled as such. Number 2, use validated age-appropriate symptom scales or decision rules to diagnose MTBI. Examples of validated scales include, but aren't limited to, the Post-Concussion Symptom Scale, Health and Behavior Inventory, Post-Concussion Symptom Inventory, and the Acute Concussion Evaluation, offered at the CDC website in Office and Emergency Department versions. Number 3, assess for risk factors for prolonged recovery, including history of MTBI or other brain injury, severe symptom presentation immediately after the injury, and personal characteristics and family history, such as learning difficulties and family and social stressors, because all of these can impact recovery and outcome. This is why it is important to have a pre-participation physical on file with pre-morbid conditions clearly documented in the record. Number 4, provide patients and their families with instructions on returning to activity customized to their symptoms. Number 5, counsel patients and their parents and caregivers to gradually return to non-sports activities after no more than 2 to 3 days of rest. The provider should offer clear instructions, preferably verbal and written. The CDC offers free resources at their Heads Up Clinician website and are easily downloadable. According to the CDC, MTBI occurs in approximately 3.8 million people annually, with those numbers rising among children and adolescents, putting this population at risk for a syndrome which can last weeks to months and affects cognitive function, memory, and sleep, and can be physically exhausting. As the number of emergency department visits for MTBI increases, so does the demand for primary care providers competent in the evaluation and management of MTBI during both the initial presentation and clinical follow-up. The CDC's 2018 guidelines define MTBI as an acute brain injury resulting from mechanical energy to the head from external physical forces. It is defined as mild by a Glasgow-Coma scale of 13 to 15, measured at approximately 30 minutes after the injury. The pediatric emergency care definition is as follows: an injury resulting from either a direct blow to the head, face, or neck, or other part of the body with an impulsive force transmitted to the head. The development of short-lived impairment in neurologic function that resolves spontaneously, though symptoms and signs may evolve over a number of minutes to hours. Neuropathological changes from the acute symptoms largely reflect a functional disturbance rather than a structural injury, and as such, no abnormality is seen on standard neuroimaging studies. a range of clinical signs and symptoms that may or may not involve loss of consciousness and typically follows a sequential course. However, in some cases, may be prolonged. There are 4 domains of signs and symptoms to be cognizant. They involve the physical, cognitive, emotional, and sleep domains. Post-concussion syndrome is a common sequela of MTBI. It involves a constellation of symptoms that includes headache, dizziness, neuropsychiatric symptoms, and cognitive impairment. 50% of patients report personality change, irritability, anxiety, and depression after MTBI. Symptoms generally occur within the first 7 to 10 days and go away within 3 months. Sometimes they can be persistent and last for as long as a year or more. Second impact syndrome is a fatal complication of MTBI. This syndrome can result in devastating consequences such as collapse, death, permanent neurologic damage, respiratory failure, and loss of consciousness. Since second impact syndrome can result from a second injury before complete symptom resolution from the initial MTBI, it is imperative for practitioners to ensure adequate recovery and prevent the athlete from returning to play prematurely. Furthermore, repetitive MTBIs over time have been linked to conditions such as depression, mild cognitive impairment, prolonged recovery from future MTBIs, and potentially chronic traumatic encephalopathy. Management of MTBI in the office setting includes having a baseline pre-participation physical with pre-morbid health history clearly documented in the record. Post-injury assessment should include a comprehensive history of mental status testing, neurologic examination including details of injury, the mechanism of action of the injury, symptom trajectory, neurocognitive functioning, sleep-wake disturbance, ocular function, vestibular function, an assessment of gait, balance, and cervical spine evaluation. Also, the acute accussion evaluation form may be used to do serial evaluations for follow-up. The provider should identify and tailor treatment plans and referrals. For the acutely worsening headache, consider neuroimaging. For the chronic headache, non-opiate analgesia is recommended, such as Tylenol and ibuprofen. It is important to monitor for overuse. For the vestibular ocular dysfunction, such as dizziness and balance problems, vestibular rehabilitation is recommended by the guidelines. For worsening sleep problems, consider education on sleep hygiene and referral to a sleep specialist as needed. For cognitive impairment, treatment is directed at the etiology and a neuropsychological evaluation is recommended. For the emotional dysfunction, a psychotherapeutic evaluation and treatment would be necessary. Provide anticipatory guidance and reassurance of the warning signs that injury may be more serious, the typical recovery course, how to prevent further injury, gradual reintroduction of activity that does not worsen symptoms, the need for social and emotional support. Offer clear instructions, preferably verbal and written, on return to activity, including school and sports, customized to the patient's symptoms. After a few days of rest, 2 to 3 days, begin light activity and then gradually reintroduce regular activities, not inclusive of sports, that do not significantly worsen symptoms. Assess school-related needs and monitor progress in collaboration with parents and school professionals. Once back to regular non-sports activities, including school, the patient may begin to return to sports using a standard progression with gradually increasing levels of physical exertion. No return to contact sports activity until symptom-free with exertion, including without the use of pain medicine. Return to play protocol, stepwise approach. At baseline, the athlete needs to have completed physical and cognitive rest and not be experiencing symptoms for a minimum of 24 hours. Keep in mind, the younger the athlete, the more conservative the treatment. Step 1 is back to regular activities such as school. The athlete has a green light from the healthcare provider to begin the return to play process. Step 2 begins with light aerobic activity. This means about 5 to 10 minutes on an exercise bike, walking or light jogging, no weight lifting at this point. The return to play protocol continued. On step 3, there is moderate activity introduced. On step 4, there is heavy non-contact activity introduced. On step 5, there is practice in full contact in a controlled practice setting. On step 6, there is full competition and the youth athlete may return to sport. Keep in mind that this requires a multidisciplinary approach from school administrators and athletic coaches. If symptoms return, stop the activity, and after a minimum of 24 hours with no symptoms, the athlete can then start again at the previous step. Primary and secondary prevention counseling can occur during the physical exams and follow-ups. Primary prevention of some injuries may be possible with modification and enforcement of the rules and fair play. Helmets, both hard, football, lacrosse, and hockey, and soft, soccer and rugby, are best suited to prevent impact injuries such as fractures, bleedings, laceration, but have not been shown to reduce the incidence and severity of MTBI. There is no current evidence that mouth guards can reduce the severity or prevent MTBI. Secondary prevention may be possible by appropriate return to play management. In recent years, there have been a series of MTBI laws passed throughout the United States modeled after the landmark Washington State Zachary Lystead Law. These laws have been enacted to improve recognition and management of sports-related MTBI with 3 common foundational principles that include recognition, education, sports removal, and return to play. The laws are also explicit that healthcare providers participate in required trainings to diagnose and manage MTBI in youth sports. I want to thank you for your participation in this educational intervention. It is my hope that nurse practitioners and other providers that may be watching this presentation will have the resources, knowledge, and confidence to make evidence-based clinical decisions and have improved management strategies when caring for the pediatric athlete with MTBI and their respective practice settings. I recommend that you take the post-test for this activity and please review the toolkit and follow the provided link to the CDC website to obtain 2 CEUs from the new learning modules created in January 2019. There is an abundance of resources for you to utilize on their website, including age-specific grading tools and downloadable educational material such as handouts for parents and athletes.